Quarraisha, please.
Professor Chen, and thank you to the organizers for this opportunity to present this morning. It's always such an honor and privilege to be here. So I should add, I was here in September for another meeting on the Anthropocene and AI. And right in the seat sat Demis Hassabis, a week before the Nobel Prize in Chemistry was announced. Now, I'm not saying anything, but I'm hoping some of that. This one. So we had special moments during that meeting, as we've had with this meeting, and I really want to commend the Pontifical Academy of Sciences for these opportunities to bring together very different perspectives and take on some of the difficult challenges that are facing us. And I think we are living in very complex times where the geopolitical landscape is unknown territory and terrains. And then we're seeing convergence of a multiplicity of issues: climate change, epidemics, pandemics, and displaced populations from wars and conflicts and natural disasters. We've been hearing about the pandemics around information, misinformation, and the list goes on. And I think science gives us hope and an opportunity to imagine a future that's different. And so I'm going to reflect a little bit on lessons from COVID for future pandemic preparedness. And listening to Eamon's comments earlier about the world is tired. We don't really, for most part, we feel we have to keep going, and there are many, many challenges. I'll touch a little bit about some of the current and potential threats, and then really focus on pandemic prevention, preparedness, response, and how do we prepare for future pandemics? How do we respond to current outbreaks and epidemics? And then close with some comments around effective partnerships and collaborations. So I think the first point that I have here, which is the best time to stop a pandemic is before it becomes one, is a point that several speakers have made in the past 2 days. And this is not about crystal ball gazing, but I think a reality if we think about potential pandemics. So where do we have current epidemics, particularly the Mpox one? Slim covered that in his opening comments around what's going on in Africa right now, the rapid spread. We also saw Marburg in Rwanda, high mortality rates associated with that. And then we're hearing from the US, the H5N1 bird flu that's spreading and already transitioning from animals to humans. And then the old one that we have and the growing one is that of antimicrobial resistant organisms coming from Africa. We've had a long epidemic of TB, and in more recent times, we've seen the emergence of drug-resistant, both multi-drug resistant TB and extremely drug-resistant TB. And then looking at the WHO global list of organisms with a pandemic potential, we've heard about the respiratory pathogens, particularly other coronaviruses and influenza. And then we're also seeing this resurgence of what is a very sad situation of vaccine-preventable diseases, including measles and polio, sort of reminder that even though we may have the tools, that in itself is a first step. And how do we ensure that communities and populations who need to benefit from these actually accept these interventions and to adopt them? Okay, so going on to preventing future pandemics, and we've heard there are challenges in UN institutions, Jeff's description, either slow or stop. But the World Health Organization is an important structure that we have. It does have a Department of Health Emergencies for preparedness and response, but it does need member states to commit to supporting it. And at the moment, it's sporadic, it's patchy, and why do we need this investment? Well, there are at least three reasons: so that we can effectively undertake the global surveillance that's needed, that we can generate the intelligence, and shout out for the Berlin pandemic hub that's already doing a great job, and then deploying teams that respond to emerging threats anywhere in the world as a key line of defense from ensuring that outbreaks don't grow into epidemics and don't grow into pandemics. And equally, we need these investments at a country level. So every country needs to have public health agencies that can be supported to do the same, which is the surveillance, because the outbreaks happen very locally. And how do you call out an outbreak of that this is now concern? How can we contain it? And how do we generate that type of intelligence? And what is that capacity that we need to build in and ensure is in place to deploy teams to respond to emerging outbreaks? And I think in the recent Marburg outbreak and also with Mpox, we saw, like with Mpox, diagnostics was not such an important issue, but with Marburg it was. And just to understand, was that a cluster of cases, was there a single source infection? Those were the challenges that Rwanda was facing when those cases were described a few weeks ago. Moving on to preparing for pandemics, and again, a point that's been raised repeatedly is we do need political commitment and support. But it's not just about a political commitment and support, but it's about decisive political leadership that's also open to science advice. And I think as scientists, well, I certainly appreciate that every executive decision is not going to be evidence-based, because there are many, many voices that need, and constituencies that need to be considered when making decisions. We've heard about, and we've experienced that infectious diseases, these pandemics, are not simply about the pathogens, it's about lives and livelihoods as well. And what's really important, though, is that we have that institutional structures with mandate to prepare for an effective response and for potential pandemic threats. And I think there's sometimes a sense of complacency, and we heard that from Carmen earlier, around how when the immediate crisis is over, we seem to get amnesia at the same time. But preparedness means preparing for that eventuality. Some of the people who work in terms of muscle response, like if you've been there, and I think in one of the presentations, we heard how the preparedness in Asia following SARS-CoV-1 enabled more rapid response. We've seen in West and Central Africa how the Ebola epidemics enabled certain interventions to be initiated very rapidly. But also important is that we need fit-for-purpose legal and financing frameworks. We've heard how protection of privacy, for example, restricted how routinely collected data could potentially be used for priority setting, understanding issues. And then, of course, the piece that's always the financing frameworks, that's not just for responses, but also continuity planning in terms of social security networks for the most vulnerable. And then how do we also look at things like food production, healthcare supply chains, and other aspects that we need for living and that needs to continue and be in place. Now we'll talk now about a pandemic preparedness plan. What are key components of that? And that includes the surveillance and epidemic intelligence. We heard yesterday about the complexities of that R&D biotechnology capacity, but we have to build that. There's need for medical countermeasures, whether that's diagnostics, vaccines, or therapeutics. Also, other devices, when we're looking at respiratory illnesses, we heard about oxygen shortages or the safety when you have a high oxygen environment ward and the fires that we saw during the Delta outbreak in India. But simple things like oximeters and others, or even masks and personal protective gear and apparatus. The healthcare system preparedness, it is about morbidity and mortality, and we start with mitigating the mortality and morbidity, and that needs strong healthcare delivery systems and also ones that ensure access and availability. Communications and public outreach, I think we've covered both in Melinda's presentation and Eamon, so I won't elaborate on that. And we started to talk about an all-of-society approach. And an all-of-society approach is more than an all-of-government approach, and it's also more than the government, private sector, scientists. It is about involving every person, and that's civil society, NGOs, and everybody who makes up our communities. And part of that also includes regional and international cooperation. So it's not just at a local level, regional level, and at a global level. I wanted to move on a little bit now to responding to current pandemics. And coming from Africa, coming from South Africa, we acutely reminded every day about multiple epidemics that we have to deal with. And I think globally, we sometimes forget about things like HIV, AIDS, TB, malaria. And I want to do that shout out for the establishment and member states' contributions to the establishment of the Global Fund for AIDS, TB, and malaria, and still needs more support. These are still ongoing epidemics and pandemics, but it's a really good example of global solidarity and leadership that has enabled us to transform particularly AIDS from an inevitably fatal condition to one that is chronic and manageable. We've seen increasing attention for the first time in like 150 years for investments in new drugs for TB and also vaccines. And then we've had some nice, lovely successes in terms of malaria. But also, how do we build local capacity and for these medical countermeasures and developing all of these diagnostics, therapeutics, and vaccines? And I wanted to also flag the Japanese investment through GHIT and particularly taking on neglected tropical diseases, and there's a whole range of those that are not listed here. And a sort of encouragement, I think, as we think about future threats is how do more countries have initiatives like PEPFAR and GHIT to address these issues. And I think we keep getting reminded in recent times that these infectious diseases are not just threats in the global south, but they are actually a challenge for the entire world. And if we can contain it in the countries where they are currently endemic and we continue to see outbreaks, then I think we secure all of us. And it's that interconnectedness and shared vulnerabilities that we have to appreciate better. And I think when we think about ongoing epidemics and pandemics, I recall Slim and I doing this piece in Science in the first 6 months of 2020, where we had about 3,000 participants in a whole range of investigational new drugs that we were evaluating for TB, for HIV, and with the lockdown looming, like, how do we stop that? And so we had to make the arguments for keeping those studies open and for putting into place mitigation plans to ensure that staff and participants coming in could continue to be, to have access to the research facilities. But also importantly, we described at that time how the lockdowns and prioritization of responses to COVID-19 was impacting services. And here I show you the impact of COVID-19 on TB, HIV care that we're able to describe, and then create opportunities for us to focus on COVID, but not forget ongoing epidemics that many of our communities were facing at that time, and continuing to do that. And I think globally, what we tend to do is our gaze moves from whatever the new thing is, and then we forget about the old. This is another reminder why we have to deal with all of the epidemics that face us. And this was an example of an HIV infected patient who was not virally suppressed, and TB is one of the most common opportunistic infections that we see associated with advancing HIV disease. She she got COVID and was hospitalized, and we were able to track almost from day one how the COVID mutants were emerging. And you can see, at day 6, the E484K, by day 71, K417T, by day 190, N501Y, and basically, this particular individuals recreated all the RBD mutations of the beta variant. And so it shows how the neglect of comorbidities, co-epidemics, actually fuel and create the space for mutations of new pathogens to emerge. We saw that with HIV, and how we had, as I mentioned earlier, multi-drug resistant TB moving on to extremely drug-resistant TB. So the reality is there's no one size fits all, but that in settings where you do have other comorbidities and immunocompromised individuals, and then you're layering on other pathogens on that, we learn a lot. And why the concern about the variants of concern? I think when we think about that first 6 months of 2020, where it wasn't the virus that was causing the hospitalizations, but it was the cytokine storm. And that cytokine storm was saying the body's response to the virus. And then with the vaccines, we sort of had hope that the vaccines will allow us to live endemically with the SARS-CoV-2, but the inequitable distributions, and as I just gave you one example of how the variants of concerns completely changed the end game, because we started to see the vaccines in itself was not protection for new variants that were emerging. The Omicron highlights that as well. I just wanted to flag one thing and to add to Carmen's excellent presentation around long COVID. And I started to talk about the cytokine storm. But then when we think about infection with SARS-CoV-2, we had a range from that very extreme clinical manifestation to mild, you're still ambulant, couldn't be home, take care of yourself. And then we had asymptomatic people. But somehow we kind of lost track and focus of people who got infected. And I think here what we see is the complexity of what we're dealing with in long COVID. So it's so many different organs that are affected, it's so many different biological mechanisms, and then there's all this antecedents we have, and I'm not expecting you to read all the fine print, but we know about age, the importance of age, we know about comorbidities, importance of comorbidities and severity of disease. And I was thinking about Professor Graham's presentation on the evolution of vaccine development and how we moved almost from serendipity, from Jenner's time, to more focused more focused design of vaccines to now where we in this precision stage. And in a way, as we move and as medicine evolves in our responses, we also need to think about COVID in a more systems approach, because it's not like a single thing and who manifests with fatigue versus some other bowel complaint or some other manifestation. And so this was like a good example, one of our postdocs, Rubeshan Perumal, who also co-chairs the GVN, developed this diagram, which I think tells you about all these different interconnected steps and visualizing it, and how we haven't spent enough time understanding COVID-19 pathogenesis, an important gap to be filled. But then we also got this big difference when it comes to treatment and therapeutic trials in low middle income country where the skills are not there. So unlike the clinical trial infrastructure to evaluate the vaccines that were put into place in terms of HIV prevention, that we could pivot that and use the same infrastructure to evaluate the SARS-CoV-2 vaccines. We don't have the similar infrastructure for the therapeutic research, for the pathogenesis studies. That's an important gap that needs to be filled in terms of skills, infrastructure, and capacity to undertake this therapeutic research. So almost at the end, you know, we, as I say, we reminded early in COVID that we are interconnected, have a shared vulnerability. But I think as the technologies came in and potential solutions, we went back to our parochial nationalist style, and each for him or herself, or each country for itself, and we forget this whole global piece. And so I think as we think about partnerships and collaborations, this may be ideal, but I don't think it's just a romantic notion. That effective partnerships and collaborations are needed and possible, but they have to be premised on mutual respect and trust. And we hear about mistrust and trust, but trust is such a common word. We keep hearing it in every situation and setting. And that part of, I think, thinking about how these partnerships can be established is that for it to be mutually beneficial, each partner has to make a contribution. And so initially those contributions may be unequal, but how do we work towards equity? And for me, what's also important is that each partner brings something that enables more to be done. So it's really the synergy that's possible by partners coming together. But we can't just do things to find solutions. We also need to ensure outputs bring added value and there's equitable benefit. So it's not just as we had with the vaccines, Africa participated in the vaccine trials, but when it came to access, we forgot some of the lessons from HIV, which is trial participants, communities where trials took place, countries where trials took place, should also have access and benefit. And I think we crudely think about outputs in terms of publications. And even there, we now see, you know, some journals are looking at if that research took place in a low-income country, and that the low-income partners, country partners, are not just glorified specimen collectors or data collectors, they're part of the knowledge generation. We're seeing more emergence of citizen science where communities that participate both in generating new knowledge, in sharing knowledge, also benefit from outcomes of that. And I think part of these synergistic partnerships and collaborations also means that we can look beyond inter and multidisciplinary research. And as I said, in thinking about a systems approach and the complex pathways things are taking place, we need to get to a level above all of what we know to date. And then just a sort of short anecdote, if time allows, Professor Chen, is, I wanted to just talk a little bit about open science and how we talk about open science, and this particular example where we contributed to providing one of the first descriptions of Omicron and its implications. And Slim and I remember very vividly, I think the announcement was made to the world by Tullio Dalla Vera and his team about the new variant of concern, and there was a lot of media coverage of it. And Richard Horton, one of the editors from The Lancet, called and said, we have to have something in Lancet to know what does this mean, not just really the description of a variant. And he gave us a couple hours to put this paper together. I don't think we've ever done this, which is prepare a paper in 4 hours. And the paper was submitted at about 5 p.m. By 5:30, we had the reviewer reports. By 7 p.m., this was live. But what happened when we did this announcement to the world, we were like, this is about sharing, transparency, openness, was that the whole region, the whole Southern African region, got slapped with travel bans. So it kind of makes you think about, how do we do this? You know, we can talk, it has to be more than rhetoric, that if we're going to share information openly, transparently, we do need to be thinking differently about it. And I think as scientists, we may have normative standards, but who decides then that executive level decision that made even at that point where 6 other countries had, that we learned subsequently, already had Omicron, here we were talking, sharing from the global south, had the capacity to do these studies, and in that spirit of openness and community, the entire region has a travel ban, which makes other scientists look at that and think, well, should we be sharing or should we be keeping this to ourselves? Now, the more secrets we have with epidemics and outbreaks, the more likely we are to have that become real global threats and so on. And I thought I'd close with this quote from a global leader and icon in our times, the former president of the first democratic president of South Africa, Nelson Mandela, who says, addressing inequalities is not an act of generosity or charity. It is a human right. So with that, I thank you.